Hi, my name's Rachel. I'm a qualified social worker and I graduated in 2017. I'm currently working at Ambition Sefton, which is a community drug and alcohol service. Being a social worker on the assessment team allows me to support individuals holistically, empowering them to recognise their own support needs.
My social work skills and knowledge base allow me to deliver therapeutic interventions one-to-one with people to support them through their recovery journey.
I suppose a question I kind of just asked myself is, why do I get up every morning and commit to this and try to kind of help individuals do this? And I suppose it's a mixture of professional and personal values. I personally feel, a commitment to social justice. I feel that comes from something within inside me, and it certainly resonates with professional values. So what do you think, Steve, in terms of that?
In terms of what helps me, or motivates me to do my job as a consultant social worker in mental health, is that I'm passionate about training or the next generation of social workers, but also working with mental health service users on their road to recovery.
Yeah.
And that can mean anything, like in terms of they've got to be the ones directing. It's a person-centred approach. The way that we work with them is to improve their quality of life. I practice in the way that I think how would I want a family member to be treated. Yeah. So that's the way that I like to encourage like trainee social workers to work with people who have got mental health issues.
And I've worked in other trust areas where they stated that you must sort your addictions out before you deal with your mental health. My experience of Mersey Care and within the homelessness team within Mersey Care has been that they take a dual diagnosis approach. So they try to work with the individual's mental health and addictions as well. There's a good liaison with all the different organisations, voluntary groups.
There's a lot of practical elements to the role, which is around safeguarding, is around MAPA reporting, is around social histories and understanding people's stories really in truth.
We are one of the only services that doesn't have any thresholds. We work with anybody, anyone who comes into police custody. We go in to work every morning. We don't know who we're going to see. We don't know what we're going to come up against. We may see someone who is one of our service users. We may see someone who's never been known to services before. It's really refreshing to be able to take that helicopter view into someone's life and potentially be the first person and first point of contact to helping them sort out the issues that they're having that have brought them into custody in the first place.
I think the big challenge of the crisis team is you don't know what you're going to come across day to day. It's trying to stop hospital admissions and treat people in the community.
It's looking at stopping the cycle early. It's about early intervention. It's about making those safeguarding referrals at the first point of contact when they need to be made.
There's very much a method and a process to working with people to take them through medium secure services through into low secure services. And sometimes I think good social work is the bit that challenges elements of that, to look at, well, what do really people genuinely need given the circumstances now. And that's about raising that to the consciousness of MDTs, talking through, debating, involving families, involving the person themselves, making that absolutely critical. Because without that story, we don't really have a lot to work on. And sometimes it's getting to the nub of what's really gone on for that person over an extended period. And anyone who's worked in social care for any length of time will know that it's characterised by service failures often.
And for all those services, we support all the community learning disability teams and other teams, but predominantly the community learning disability teams, to support service users who have got a diagnosis of learning disability and or autism, so it could be both. And that service there hasn't been that service within GM, and I think within LANGS, apart from the forensic support service, but this service with a different specification hasn't been there. So it was like breaking new ground, and the challenges were trying to build the service whilst actually providing the service at the same time, because there was no footprint to follow, and there was no compass to guide us from previous teams. We work across a number of issues, around safeguarding, victim liaison, multi-agency public protection arrangements, work with sex offender units as well, in GM and also in Lancs, any child protection issues. So there are quite other responsibilities that we do have within the social work team of SST.
She just felt that the world was closing in on her and she couldn't cope. So it was looking at how can we help her and how can we help stop this cycle. Where can we actually draw the line and sort of join up the jigsaw to try to help her move forward, and we were able to do that. One of our support workers went out and sat down in a multidisciplinary way and made sure everyone was talking to each other, because all the services were there, they weren't talking to each other. As a social worker, that's what we do, it's about working together. So in this case it was a really, really good outcome. She was supported. She's now on her way to a detox program. Once she's through her detox program, she'll also receive some counselling. And I think just being able to step back and look at what was happening, how all those services were there but no one was really talking to each other through no fault of their own. Everybody's looking at what the issue is in individually. So and I guess that, going back to the point that we don't have a threshold, we look at everything. It's we don't know what we're going to get, and I think that's, I suppose, an example of some of the cases that we come up against.
I mean, I think that piece of work that Jenny, you've done this week, well, for the last few months really, with where you've been working with that patient that came in from the community, who had the injunctions in place, who had the accommodation, who was in the process of having a home repossessed, and now you've helped her to manage that difficult process, and the advice that you've taken from different colleagues. I just think that to me is a fantastic example of social work at its best. That really gives me it makes me proud, really.
Yeah. It does kind of make you feel good about it, and obviously in that case, her not having family, and it's kind of being that person, isn't it, to try and put everything in place to sort them things out and stuff, and you never really know what you're going to get faced with, I suppose, and it's just on a day-to-day basis dealing with the unknown, isn't it? And
something new every day,
isn't it?
And you take on different roles and you do different jobs and you pick different things up, and it's all dependent on that person. I said this one didn't have family, so there was roles that you pick up that you wouldn't necessarily have to do with anybody else. It's just all sorts of different things.
It's the diversity of it all, isn't it? Because one day we can be talking to the police, they'd be coming in, we can be an appropriate adult, and the next day you're supporting a really quite upset family member that's going through, maybe the loved one's been through the criminal justice system and they've ended up with us because they've become unwell. It's being that link person for me anyway. That gives me the satisfaction of being part of this profession, if you like. And
these people have been through trauma, haven't they? So the families have been through trauma, and it's like, it's sort of providing a role for them in a different way, isn't it? Because they've been through a lot of stuff, and it's helping them sort of work out that their like close relative is here, and it's stressful and it's scary, isn't it? And it's sort of providing reassurance, but information. It's all different sort of tasks, really.
It's not just a single person you're working with, is it? It's just like, there's a family as a whole that, there's so much going on with, and it can be quite frightening and sort of not knowing really where
but picking that up, I mean, it's even that, it's bigger than family, isn't it? It's the community. You're sort of working with probation, police, local care coordinators, local authority, that in themselves are under really lots of sorts of stress because of austerity and the lack of resources, and it's sort of getting them, if you like, to sort of take their responsibility in regards to 117 responsibilities and allocating care coordinators. That in itself can be a battle, can't it? I found it really difficult.
Definitely.
You know.
We know over the last 10 years the degrading of community services is significant. We all work within more limited means than we've worked with historically, and we have to be ready for that.
It's being able to stand up for what you believe in.
Yeah, definitely.
You know, bringing that voice really for people that, you know, often go unheard.
It's working out your role within the MDT, isn't it? It's like, everyone does have different opinions. That's natural, isn't it? You aren't all going to agree on everything, but it's like coming together to sort of work out what's best for the patient, isn't it? And move on from there, really.
And I do like that, the fact that there's, you know, a number of disciplines that, you know, get together and consider everything as a whole, and, you know, that is absolutely like essential, isn't it, really, for someone moving on. You know, people generally here for a long time, and, you know, that time and that sort of consideration.
You see them sort of progress and get leave and move on, and you see them going into their own flats in the community sometimes, and they're all the more positive sort of parts that you can see someone sort of how hard they've worked to get to the end
the
point,
team,
really.
The team have worked hard to get them to that point, and it stays with you, that feel good factor.
It does,
You're kind of taking a step back and you look at the whole, what's going on and what we can do as a service, as Mersey Care. I have knowledge of what's available, and we can try and make this better, even though, you know, obviously dementia doesn't go away, but there's lots of things that we can do to manage and give someone a quality of life. And the reason why I chose Mersey Care was because it was integrated. So we were going to work closely with different disciplines, which I felt was an excellent opportunity, because then I get a case, I can walk over the office and say to someone, the carer's here, have you been in? What do you think? Get some expertise with medical, the carers that are coming in on a daily basis to see what's really going on in the family, and have a little bit more insight for me just walking in there to assess for an hour, and we can work together. And that's why I chose Mersey Care, because I think it makes a very solid assessment, and the outcome can be just fabulous.
There is no medication that can actually cure something like social isolation, social exclusion, poverty, and maybe someone being deprived from a particular service. So, and again, that is where we think that medication cannot always be a quick fix to everything.
He kept saying if I was a doctor, and I said no, I'm not a doctor, and then he just didn't want to know me because he wanted a doctor and he wanted painkillers.
You tend to realize that most of the service users or the people who actually access our service, they have other difficulties, they face other challenges in life, not only the medical and the physical health aspects. Is always a good starting point to make the medical professionals or nurses to understand that health is not only physical. We need to bring some other aspects to kind of cover the holistic aspects. That is why we don't only depend on the medical model. We have to chip in the social model to try and help the person as much as you can.
How do you feel service users feel about seeing a social worker, mental health practitioner rather than a nurse?
Well, I think that again, if we go back to what social prescription is all about, you realize that there is medication for physical health, there are medications for mental health, but then if you bring this aspect of social prescription, which is the social work knowledge, you tend to realize that we try to cover health from a holistic perspective. So I think in a way, and especially in cases cases where maybe a service user is being maybe isolated because of social, economic and other environmental factors. So if we refer them to services or day centers where they can actually get some of these issues resolved, I think we'll achieve a greater outcome rather than just limiting ourselves to the medical model.
It's about how do you move things on from what you think and feel to how do you evidence and support this, and that's about what you do in that moment, but also what you bring as a social worker with all the kind of understandings, the eclectic nature of how social work should function done well, how you can piece together different approaches, theories, perspectives to make a cohesive plan for an individual. It's about asking the questions, does it really have to be this way? Is there a better way? Understanding the person and their story, understanding the family story and how that interacts with the person's story, but also looking about how services work for that individual and then how are they going to work going forward.
We're also getting people who are escaping persecution and forced marriage. So, you know, we're coming, as well as sort of standard cases, we are coming across individual cases that are interesting and challenging and got an emotional edge that we've made the difference from. And it's sort of sometimes in those cases without social workers that they're considering the holistic issues. They could be just treated with a tablet which doesn't actually manage the underlying issue of fearing persecution, dealing with the underlying domestic abuse and risk issues, and liaising with other agencies to make sure someone's both mentally safe but also physically safe.
One of the parts of the job that I really enjoy is resolving any safeguarding issues. So I get a lot of satisfaction of if you like pinpointing or highlighting what I see as safeguarding issues and resolving them, you know, bringing them to the attention of the consultants and the rest of the MDT, making the local authority aware and the strategies that we then use to make sure that that person is safe and safeguarded.
I think I learned something as a practitioner, although it's something that we probably all know as practitioners, but I think the lesson there is our service users are their owners of their own change. We can try and do all these things, but if they do not buy in, or if we don't allow them to take ownership and drive that wherever possible. I understand some service users can't do that, so it's not going to be for everybody, but I think for those who can, which is a majority of them, we should be allowing them to be the drivers of that change. And I see it in a lot of my service users I work with. You know, if you give them that chance to be responsible for something and be accountable for it, for that change, and take that, you know, that credit for that change, they are likely to stick with it. With support, of course, but I think it is important to recognize that, rather than thinking, well, I'm going to be the one doing the change. It's more like, well, can we do this together? Can you drive this yourself forward?
It's really humbling to see the struggles and the difficulties some people have, and not just the vulnerable adults and young people that we deal with, but their families as well.
It's definitely not for the pay.
It's not for the money.
No, all the bad press and media that we get.
Oh no.
So no, it's you know, it means a lot, really. Sometimes it's hard to quantify that, isn't it? How much it means to us all, and how hard we work to make sure that, you know, our profession is respected. You know, in the clinic and amongst other professionals. You know, our good name is important to us. I think we all agree on that, don't we? Yeah.
Everyone is our customer, if I can say that. You know, it's everyone that we see. So I think that's how our team and how, as a social worker, we can make a real difference, and how Mersey Care is forward thinking in that way.
But I do love social work, and as well, because I'm too talkative, I can't keep my mouth shut, so kind of works well. in that sense.